I'm happy to go ahead and kick us off.
Yeah, let's do it.
All right. So, hi everyone. Welcome to tonight's IG Live, which is dedicated to colorectal cancer prevention in millennials. From those of you who are new to YMyHealth, my name is Melissa Schenkman, and I'm the founder of YMyHealth, which is a health resource that is produced for and by millennials. What we do here at YMyHealth is break down complex healthcare, always with people in their 20s, 30s, and 40s in mind. And we cover a range of topics that include heart health and fitness, mental health, young people and cancer, and so much more. Check us out at YMyHealth.com and here at YMyHealth on Instagram, as well as TikTok and LinkedIn. And we also have a bi-weekly newsletter that you can sign up for on our website for free, and I'll give you early access to new content. It is a tremendous honor to have Dr. Fola May here with us. She is just Hello. She is just an incredible advocate. You are an incredible advocate and champion for colorectal cancer prevention and young people. You're welcome. Just really for young people and truly people of all ages, I was going to say, as well. And she is a fellow millennial and an associate professor of medicine in UCLA's Division of Digestive Diseases, and also you're the Associate Director of the UCLA Kaiser Permanente Center for Health Equity, and we're going to be talking about some of that work tonight, and the Director of the May Lab, where you are doing wonderful work. Her team is doing research that focuses on improving healthcare outcomes for patients with digestive diseases, including understanding what some of the barriers are to colorectal cancer screening and finding ways to decrease those and get more people screened. She is also on the board of directors for Fight Colorectal Cancer, which is one of my favorite organizations. Yes, strong on there. And that is how we met actually at the Fight CRC Call and Congress event, which was wonderful in March. Tonight, we're going to talk about several things: the evolution of the lowered colorectal cancer screening age, kind of how that all came about and where we're going from there, age-related healthcare disparities affecting millennials, genetic testing, new screening methods that we're hearing about, and much more. But first, again, welcome, Dr. May.
Thank you so much for having me. I'm so glad that we were able to make this happen.
Same here. Thank you so much for joining us. Very, very excited for our discussion tonight. Just before we get started, I just want to remind everybody, if you have questions, please put them in the chat as we're going, and we will get to as many as we can at the end. So I want to begin kind of looking at the big picture, right, view of CRC, as we call it for short. You know, the last few years, colorectal cancer has received a ton of media attention, and I think it's almost more and more each year is what I notice. Even in 2024 alone, there have just been a lot of stories, and the stories, I'd say they fall into kind of two categories, but one of them is the rising numbers of cases in people under the age of 50. And most recently this month, there was a report in a very prestigious journal, The Lancet Public Health, that was saying that after looking at cancer trends for many years for people born between, I think it was 1920 and like 1990, they found that millennials and Gen X were facing higher risk of multiple types of cancer, including colorectal cancer, more than older generations. And back in March when we met, I learned of the staggering number, which is the prediction of 27,400 people under age 50 being diagnosed by 2030. And we all worked together to place that many flags on the National Mall, which we did. And so I'm wondering, we hear all these things, we hear these stories, we see these numbers. You know, as young people under age 50, how should we put them into perspective? As we each navigate our own healthcare.
Well, first of all, thanks for having me and for talking about this topic. And I know it's one that is getting a lot of attention, and the most important thing to me is that people get the right information, and we don't want to be alarmist, but we want to be informational, right? And I think what's really interesting about this disease is it wasn't too long ago that we really thought of this disease as a condition that only affects older people. I remember when I was in medical school, not that long ago, they used to teach us that this is the disease that you'd see in people in their 60s and 70s. It's completely different now. When I'm training my medical students now, I'm telling them that they need to consider this diagnosis in someone who's in their 40s and 50s. So there's been a big epidemiologic shift, and the shift, unfortunately, is downward towards younger people getting this cancer earlier in life. Now, I want to be clear, it's still the most common when you're older, when you're over 50, but we are seeing it creeping downward. And I think we're going to talk into a little bit as to why we think this is happening. It is the reason why we changed the screening guidelines. We used to always say that when you turn 50, your birthday gift is that you get to get a colonoscopy, you get to get screened for colorectal cancer. But now we're screening at 45. And the reason that we're screening at 45 is reactionary to that data. It's because we're recognizing that this is happening in younger people. And in order to prevent people from dying from this disease unnecessarily, we need to start screening earlier.
Yeah, no, absolutely. And we definitely are going to dive in more to that, because I think that is one of the top questions on people's minds a lot of the time is the screening age, for sure. You know, what do you think kind of the role of health literacy plays for millennials in their decisions about going to get screened, about hearing, you know, they hear about genetic testing, which we're going to talk about more tonight. Where does that health literacy factor?
Yeah, I think the big thing that's happening with millennials, honestly, is lack of health information. And then when they do get health information, sometimes it's misinformation. So you're young, you're healthy. Many people are fortunate to be young and healthy, and they don't have to see a doctor on a regular basis. So they might get into their 40s or even 50s. And we see especially young men will get into even their 40s and 50s without ever seeing a primary care doctor. So they're not even getting this information that they are now eligible for colorectal cancer screening. So that's the number one problem I see, is that we just have young individuals in this country who feel very healthy. They don't seek regular medical care. So that's why I'm always pushing that people get a primary care provider. They see that person just once a year. I make my appointment every February. Every February, I see my primary care doctor, and just stick to that. And sometimes you will have things to talk about, other times you won't. But most definitely, especially when you start hitting your 40s, that doctor is going to start bringing up things that you need to get tested for. And it's cancers, it's things like diabetes, it's weight management, it's checking on how much you exercise and nutrition and diet. It's a lot of things, but it also includes colorectal cancer screening. So I think that's the health literacy problem, is that we're just not recognizing that we are at risk and that this is for us. And then when we read about it, it's this very alarming thing. So then people go from 0 to 100, like, oh my gosh, I have cancer. You know, I can't even tell you how many alarming texts I get from people. And so we just need to be aware, but we also need to know that what the symptoms are. So what I tell people who are young is you get screened at age 45, unless two things. If you have a family history, we're going to start earlier. We're probably going to start at age 40. But we're actually going to start even earlier than that if you had family members who had colorectal cancer at a young age. So we say the guidance is 10 years before the youngest family member was diagnosed. So if you had a family member that was diagnosed at age 35, you're going to start your screening at age 25. The other exception is symptoms. So if you are having symptoms that we recognize as consistent with colorectal cancer, we're not going to wait to 45 for you to get checked out. So these symptoms are diarrhea that won't go away, constipation that won't go away, abdominal pain that comes and doesn't go away. In addition, if you are having weight loss, if you have iron deficiency, which is low iron levels, and that can't be explained by some other reason, these are all reasons to see a doctor and likely get a colonoscopy even before 45 if you're developing those symptoms. So I think if we can follow those three rules, as young adults, we're doing pretty well.
No, absolutely. And one thing I just want to follow up with you on that is polyps. That's the other thing that sometimes brings some confusion, because you say, okay, I don't have colorectal cancer in my family that I know of. And then people who've asked if they know, they know. But I do have family members who've told me I've had a polyp or I've had multiple polyps. What do you do when you're hearing that then?
Thanks for that question, because it's really important and it's confusing. And the way that I like to explain it is that all colorectal cancer starts with a polyp. And we're actually kind of lucky in this disease that we have the precancerous polyp. So polyps are little bumps, they look like pimples, right? And they grow in the lining of your colon. Most people are going to develop them over a lifetime, but some people are going to develop them earlier. Now, most polyps will just stay pimple size and never cause cancer. But there's a small percentage of them that has this potential to grow into a cancer and grow and grow and grow and cause major life problems, obviously, right? So when we're screening for colorectal cancer, we're not only looking for early cancers, but we're looking for those polyps before they turn into cancer. Because if I can do a colonoscopy on you and take out those polyps before they turn into cancer, we're lowering your risk of developing colorectal cancer. So yes, if you have a family history of polyps, specifically the adenoma type, which is the precancer type, then we also want you to start early. We want you to start at age 40 or 10 years before the youngest family member. So yeah, we can count that as a family history. And to be very clear, when I say family history, I'm not talking about your third cousin removed's best friend. I'm talking about your mother, father, brother, and sister. So it's really kind of your first degree family member that we worry about.
No, absolutely. That's incredibly helpful. And I know for a lot of people, the polyp question always seems to come up. So I really appreciate you explaining all of that. Thank you.
Of course.
So I want to talk about something else that I think, much like the polyp question, is always a popular topic. Kind of the evolution of this recommended screening age, which is now 45. How has this changed in recent years from 50 to 45? And who is this change important for or positively impacting, would you say, so far?
Yeah. So, we haven't been screening for colorectal cancer for that long. We started in kind of the 80s and 90s, really. It's kind of a newer preventive service. And we've always started at around 50 because, as I said, all the data showed that this was a disease that happened in your 60s and 70s. So we thought we were even safe starting in the 50s. But when we started looking at data, probably about 10 years ago, there started to be a question of, are we seeing this cancer in younger people younger than 50? And it was actually the American Cancer Society, I believe in 2018. That was the first society that came out and said, whoa, we should start at 45. Now, some people followed suit, but because the insurance companies weren't covering it yet, not everybody was able to follow suit. And it wasn't until the United States Preventive Task Force in 2021 made the declaration that they agree we should screen at 45, that we were all able to get insurance coverage to start screening for colorectal cancer at age 45. And that's because of the way that the government has set up coverage policies through the Affordable Care Act. Screening is covered for everyone, which is good news, but it's the United States Preventive Task Force and that specific society that has to say it for it to get covered. So we were waiting for them to put the hammer down and say we should all get screened at 45, and that changed everything. And the last 3 years, we really have been trying to get the word out about that because, believe it or not, there are doctors who aren't aware, there are patients who aren't aware, and we've also been trying to introduce interventions into clinics, into healthcare systems, doing informational sessions like this one, just to make sure that younger adults know that they are now eligible and that they get into their doctors and they get scheduled. And the good news is many ways to get screened. You can get screened with a colonoscopy, you can get screened with one of these at-home stool-based tests. So we have lots of options. The key, though, is just to get started at the right age.
Oh, absolutely. And so important for now, which it's hard for people to believe, but the oldest millennials too, who are at average risk,
that would be me,
are getting up there, right? That's what I'm saying. That's what I'm saying. It's like, wow, does that refer to me? But yeah, because I think people are maybe who, like you said, are missing it and thinking, oh no, that's like far off for me. But yeah, it's interesting. It's only a few years, surprisingly.
Yeah, no, I have friends who are just getting there. So when they hit that 45th birthday, you know what my card's gonna say.
That's great. No, absolutely. Well, I want to change gears slightly to talk about the health disparity side of things, because we often hear these terms, and I think even more so, honestly, since the pandemic. I think they're kind of more in the lay audience world, but we hear the terms health disparities, health inequities, health equity. Most of the time, the thought is that the focus is on defining, it by ethnicity and by race and gender even. And that is all 100% true, that there are different disparities facing different groups based on those characteristics. But there are also disparities and inequities found in lots of other ways. And the way I'm thinking about, of course, is age and younger ages. As the associate director of UCLA's Kaiser Permanente Center for Health Equity, and someone who's dedicated your career to research, that aims to address these health disparities, how would you say age-related disparities in healthcare are affecting millennials' access to colorectal cancer?
It's a great question. Thanks for asking it. And
you're welcome.
Our team here, we're obsessed with disparities and inequities, and the reason why is because unfortunately there are populations of people who live at the fringes and who have the worst health outcomes, simply, honestly, sometimes just because of the neighborhood that they were born in, or the unfortunate circumstance that they were born in. We call that social determinants of health, right? So disparities are differences in health outcomes. Inequities are differences that arise because of unjust scenarios. So because of where you live, because of where you work, because of the family you happen to be born into, because you're unemployed, you unfortunately are in an environment or setting or situation where maybe you have poor access, or maybe you have poor access to good nutrition, or you're in a place where you're exposed to an environmental toxin. These are all the differences that lead to inequities because they're unjust situations. So our team focuses on understanding why that happens, and then we create interventions to try to eliminate those inequities. I think for colorectal cancer, what I always try to impress on people is that this is the disease that affects everyone, right? Like we hear a lot about breast cancer and prostate cancer. Those are sex specific. Colon cancer affects men and women. And then across age groups now, we are also saying that colorectal cancer can affect you at many different ages. When we look at age disparities, it's really going to be the extreme. So we see disparities for people who are older towards the end of their life, and we see disparities for people who are younger, earlier in life. And again, the issues that we see with younger individuals is an assumption of good health. There's an assumption in the individual that they are young and healthy and invincible. And for that reason, they don't seek care. They don't seek care when they're well. And they also don't seek care when they're sick. They wait too long. And that's why, unfortunately, I am too often in a situation where I'm telling a 40-year-old that you have an end-stage cancer that probably started a year ago or so, but you unfortunately ignored those symptoms because you thought they were going to go away. So a lot of the disparities we see in the younger groups are either because people are not paying attention to the symptoms, or they don't have the access to care. They don't have the employment that gives them the insurance access, or even if they do have the employment, they're not seeing their primary care doctor on that regular basis like we talked about earlier. So a lot of the work that we do around eliminating disparities in younger adults is making sure that the information's out there, that it's right, that they have access to care, and that people know when they've gotten to the age that they are appropriate for different preventive care measures.
No, that's absolutely wonderful. And to your point about some of the disparities that are being faced, as far as our age group, finances is one that always comes to mind when we talk about access. So kind of how, in your view, does that financial aspect of healthcare decision-making differ for millennials compared to older generations?
Yeah. There's this fear of the surprise bill. Okay. So this is the concept that, like, you go to your doctor, you have like this great interaction, you're like, this is great, I saw my doctor, I got all these referrals, and then like a month later you get this crazy bill in the mail, right? And in America we're used to this. Like it's just how healthcare runs. I was working for a while with a Dutch researcher who was in the US doing some work in our team, and he was like, this is a crazy concept. Imagine going to dinner and having a wonderful meal with someone, paying your bill and leaving, and then 4 months later a huge bill appears in the mail for you to pay for this dinner that you had 4 months ago. And that's kind of how we serve healthcare. So unfortunately, because we have this history of people of kind of non-transparency about cost, when you're healthy, I think sometimes you just want to avoid that situation altogether for fear that you might accrue cost. So a lot of times I try to remind people that your preventive healthcare services should be covered. And if you are getting a bill for appropriate preventive services, you need to fight that. You go to your provider first, you go through your health system, you talk to your insurer. those should be covered. And then I say for other services that you're not sure are covered, call your insurer. It's kind of painful. You're on hold for some time, but they'll tell you what your policy covers and what it doesn't cover. And you might have some more confidence in getting that extra referral or getting that extra test. But hands down, colorectal cancer screening, especially when you're 45, and if you're 40 with a family history, should be covered by your insurance plan. And you shouldn't have to worry about costs.
So that's really, really helpful to hear. And I appreciate you talking about that, because that is definitely one of the things that all of us face, but even more so, I think, at this age. And I love the surprise bill. I've experienced that too.
It's crazy. I mean, think about it that way. It's kind of
hurtful.
crazy. And it's hurtful. It's harmful because I think it pushes people away from seeing the doctor.
Oh, I know. And you guys are totally, the finances, I know. The billing department's not the same. It's a totally different department. We tell people,
Exactly.
you know, and there's only so much we can do because of the way the system is set up. But another thing that I think is a tool in our prevention toolbox that a lot of people might not think about, and this also would involve a little bit with insurance too, finding out, but is genetic testing. And I know you are a big proponent of genetic testing. So why, in your view, is this so beneficial and something we should look into?
Yeah. So genetic counselors are relatively new to the medical field, and I'm excited about it because we're training more and more people in genetics counseling, which means that more and more people will have access to it. Not everyone needs to see a genetic counselor. We typically say that we want to consider genetic testing if you're diagnosed with colorectal cancer under age 50. There are other cancers like endometrial cancer. We don't usually see that in young women. So if we see it under 50, we're going to suggest that you get genetic testing. Families where there's multiple cancers, particularly multiple of the same cancers, and meaning on the same side of the family, blood-related family members, we definitely are going to want to suggest genetic counseling and genetic testing. And then there's certain types of tumors. So some of the colon cancers that we take out when we send them to the pathologist to look at under the microscope, there's certain markers and cell types that raise our ear or our concern about genetic syndromes. So there definitely are cancers that cluster together. They cluster by families, they cluster by types. And if you happen to be in one of those families where you're seeing a lot of breast cancer or a lot of colon cancer or a lot of endometrial cancer, uterine cancer, same thing, you're definitely going to want to make sure that you at least mention to your doctor, hey, do you think that it's reasonable for me or my family members to consider genetic counseling, genetic testing? And it's that genetic counselor who's going to be the one who tells you what tests to get and who else in the family should be tested. And they do this elaborate family tree. It's like a whole pictorial thing, and they decide which person needs to get which test. So I do recommend that for people who have these red flags in their family. And again, this is something that should be covered by your insurance as long as you're doing it appropriately. And when you're not sure, again, another time to call your policy up, your insurer up, and ask about your policy to make sure it's covered.
No, excellent points. And I'm curious on the insurance side, I just want to ask one thing. You know, let's say, so the information that you get back is incredibly helpful. It can save lives. It can help you take preventive measures earlier. But I'm wondering, let's say you do get certain, which is the purpose of genetic testing, certain things positive back, either eliminating risk or letting you know that you may be high risk for something. If you find that out, have you found in some people's, different cases, like that it affected their insurability or their insurance rates and ways? Because I think that's something that the people in our age group kind of wonder about. They want to take that step, but before they take that genetic testing step, they just want to know what they're potentially in for on that side of things.
That's tough, right? And this is another one of those things that's unfortunate about how the middleman, the insurers are set up sometimes. It should never eliminate you from an insurance policy, but I have heard about situations where the premium increases or changes. It's unfortunate, and I have seen people try to fight it. I think in the end, though, that these changes are pretty minimal these days, and the reality is that you do warrant more medical attention. It's probably the last time you should unenroll yourself from health insurance. And I say if you have the insurance, then you should really use it, right? Like get all those referrals that are covered, make sure that you're getting all the testing that you need, because if we pay for prevention, we actually save a lot of money, time, and years of our lives than if we get diagnosed with a cancer and we're trying to pay for treatment and trying to survive. I can't tell you how many patients I've taken care of who regretted waiting too long. And they said it would have been so much easier to deal with these symptoms a year ago than the cancer I'm dealing with now that is incurable, right? So you really have to take that into account, that you are thinking about preventing further loss in, days of your life, your healthiness, your quality of life in the future by taking care of things early.
Absolutely. No, incredibly, incredibly important in the way we all should think about our health and how we want to navigate our healthcare. Absolutely. I know that we both wholeheartedly agree that education and awareness about CRC is key to prevention, and which is what we're doing on this live. And in your experience, are there any innovative approaches or programs that you've seen that have successfully increased CRC screening rates, but especially I'm really curious in people under age 50?
Yeah.
Looking at things. Yeah.
We're still learning a lot about the under 50 population. And, we actually did a big study here at UCLA to try to figure out how to reach that population best. We did 4 interventions and we haven't released the results just yet. We're going to publish it soon, but we wanted to see what young people were most responsive to. What we've learned from people who are over 50 is that people really like to be handheld and people like things to be as easy as possible. And I get it. There's so many competing demands right now, whether it's, putting food on the table, to holding them several jobs that you need to driving in traffic in the city you live in. Yeah. There's just so much going on that we have to simplify preventive services for people. So things that have been effective, mailing people screening tests. There's a FIT test, which is one of the stool-based screening tests. We at UCLA, we mail that to patients. So they open the mail one day, the test is there, it has instructions on how they can complete it, and they can mail it right back, and it's all covered.
Oh, that's great.
So mailed interventions are really popular right now. The other thing that's really popular right now is patient navigation. And this is really helpful, especially when you look at like minority populations, underserved populations, and we think young populations too. This is the concept of not necessarily a doctor, but maybe a nurse or maybe a health educator calling patients and saying, you're due for screening, why haven't you done it? And then they present their specific barriers or challenges. And with that navigator, you address those challenges until you walk the patient through actually getting the screening test done. And those navigation interventions are extremely effective, whether it's getting someone screened or getting someone into cancer care. So we lean on those interventions a lot. I've seen a lot of really creative things that are coming out, screening tests being available public. You can even get a screening test at CVS now. Lots of questions about who's going to follow up on that. But we're just trying to make them more accessible. Yeah.
No, that's all very, very interesting. I'm curious, when you're saying about patient navigators, the first thing that comes to mind from past work is community health workers. Then the use of them, I think, would be, and I'm assuming that might be part of what you're talking about, where you have people within your own community who attend. For those who might not know about this, they live in your neighborhood, they attend, different neighborhood type activities that you do, and, same church, synagogue, things like that. Kids go to the same school. And so that person is educated in a particular area, like with what you're talking about with CRC screening, and then able to kind of do the hand holding. I think that would be interesting.
Yeah. And I think also key to that is meeting people where they want to be. So going to them, going to their communities, and also working with allies in the communities who they trust, right? So we've done a lot of work working in ethnic churches. We've done work working in community health centers. They don't necessarily want to hear a fancy doctor come in and tell them what to do, but they might take that information better when it's coming from a community health worker in the clinic, or someone who's working, a deacon in the church, right? So there are very effective ways that we've learned, especially in health disparities research, how to reach communities and underserved populations in particular by working with individuals that they trust.
Oh, that's wonderful. That's wonderful. And I'm looking very forward to seeing the results for the younger generation too, I have to say.
I gotta finish writing it.
So I'm very excited. I look very forward to that. Well, as we wrap up and take questions, there's a lot of research on the horizon when it comes to developing new screening tests. One of the newest ones that has been receiving some press since I want to say like end of July, beginning of August, is the Shield blood test. And I wanted to just have us talk a little bit about that. Who's a good candidate for it? Who's not such a good candidate for it? So maybe we'll start there.
Yeah, absolutely. It's actually kind of an exciting time for people like me who like to geek out on the science of cancer screening. There's a lot going on, and we're so fortunate in that in this particular cancer, we have a lot of ways to early detect and screen. So we've got these stool-based tests. We have the colonoscopy, which is the visual examination. The colonoscopy allows us to take out the polyps at the same time as finding them. The FIT test and the stool test, like Cologuard, you might have heard of from Exact Sciences, those work a little bit differently. They're testing the stool for signs of cancer, and if those light up as positive, then we do the second step, which is the colonoscopy. There's also virtual colonoscopy, and there's a lot of tests that have been out there, but the newest one on the block is this concept of liquid biopsy. This is the idea that you can go into your doctor's office and get a tube of blood drawn, and they can check your blood for signs, early signs of cancer. The biggest difference with these tests, like the Shield test, is that they're not going to find polyps like the stool-based test and the colonoscopy are going to do. So they're pretty good at cancer detection, but they're not going to be as good as finding those precancers. So I'm excited about the liquid test because I think it will capture people who've been very hesitant to participate in the other modalities. So we'll recruit more people into this pool of people who've been screened. But I'm a little bit nervous because I do want to make sure that people understand that the test is a little bit different. And you're not going to see that prevention benefit that you will see if you get a colonoscopy or some of the higher performing stool-based tests. So I think right now, as physicians, as public health experts, our goal is to make sure that people just understand the differences. And I sit down with patients, I explain the test to them, I tell them what they do and they do not do, and people will prioritize what they want to prioritize and make the best decision for them. So an informed decision is what matters. But yeah, we've got the liquid test coming. There's going to be even more fancy stool-based tests that are better at detecting polyps and cancers. And then the big one that's also coming soon is these are multi-cancer early detection tests, MCED, MCED. This is the idea that, get this, that vial of blood we draw, it's not just looking for colon cancer, it's looking for 6 or 7 cancers.
Wow.
In one row. Yes.
That
would be impressive. And in an ideal world, it's a beautiful thing, right? But again, we have to think about the unintended consequences of these tests and missing things, and also potentially the diagnostic tests that people will have to get when these tests light up as positive. So a lot in the field that we're going to have to sort out in the next few years.
Oh, very, very exciting that there's so many different options and kind of where things are advancing to as well. And the one thing I did notice that I was curious to ask with the Shield, and I'm guessing this may be the case with the others, is that they're only approved, at least the Shield is, far to my knowledge, starting at 45. And so I was wondering, so for our fellow millennials, kind of, why do you think it's only being approved at that age? Because I guess some of us, we will read the headline and we'll say, okay, this is wonderful news. Now I have now there's an alternative. Oh, and I bet this alternative is maybe for me because this is easier before reading what it does. So I'm wondering as these different modalities are coming about, if there's going to be a thought on changing that age too. So a kind of two-part question. One on the Shield test, why 45? And then also as these other advances are coming, are there conversations about changing the age?
Yeah, and this is the most frustrating question I probably get when I go around and talk about colorectal cancer. It's the people who are under 45 who are getting sick, and they say, I love all that's happening, but none of it would have helped me. And unfortunately, we don't have a solution for that just yet. The reason why the Shield is 45 and older is because they did a study with tens of thousands of people, and they started with people in their late 40s. So they cannot then recommend it for anyone younger for that age. So it's the science. And Will it change? I think it will in time, but it's going to take years for us to develop more science to support a younger age. So I don't think that's immediately on the horizon. What I really focus on our younger than 45 adults is paying attention to those symptoms, not ignoring them when they come up, seeing a doctor regularly, making sure that if you develop those symptoms, it isn't pushed aside by you, your family member, your friends, your doctors, that you get a colonoscopy. Because the reality is that if we can pay attention to symptoms, we're going to catch this at a time where we can probably intervene and help you out. But unfortunately, right now, we just can't recommend any of these tests to people under 45 unless they have a family history.
Well, that's understandable based on the science and what you're saying. And I appreciate you also bringing up, because there are so many tools, thankfully, at our disposal that we can use in prevention, even when we are younger than that 45, mark that we need to reach. Well, I'm just going to see if we have any questions in the chat. So hang on one second.
Okay.
Let me see. If not, I did have a few that came in earlier. So.
Okay. Sounds good.
All right. Let me see. Nope, none in the chat. So if anybody has any questions, now is your time to put them in the chat. But while we're waiting to see if anybody has any, I was going to say, some of the things, one of the things, and you were starting to talk about towards the end, that people had asked me is, what will it take to lower the age, regardless of what that lower age is, which I know there is so much of a debate on what that exact number would be, but what would it take to even bring it to 40? In your view, you're involved in so much wonderful advocacy work. What do you think, and what should people know about that?
Yeah, I think about that event where we met in Washington, D.C. and, as a physician, how incredible it was to be at that event and to hear, I think we even heard like an 18-year-old, right, get up and tell a story about being diagnosed with colorectal cancer. So the advocacy is essential. It's essential for us as doctors to hear that this is happening, that it's being missed. It's important for policymakers. When I go to the Hill, which is at least 3 times a year, I need those stories to tell our congresswomen and men, like, that this is happening and this is why we need policy change. So that's one thing. The other thing that is a little harder is we need the science and we need the numbers. So in a life before this, I was an epidemiologist, so I understand to the core that, we study the trends of disease, and a trend will be happening, but we're not going to see that trend until a couple years later, right? And that's what we saw with colorectal cancer. It was probably creeping down before 2018, but it wasn't really until 2021 that we were all very convinced. So it might actually be happening now. It might still be creeping down now, but we might not know for a couple of years. So we need the really incredible scientists, like the ones at the CDC, the ones all over the country and world who are studying this, to really get into following those trends, presenting that data to task force like the United States Preventive Services Task Force. They will review the data, actually just in a few years. They'll review the data again and they'll tell us, are we going to stay at 45 or are we going to lower to a lower age? And until then, we're just trying to spread information and paying attention to symptoms.
I appreciate you explaining that, because I know that is one of the top things people do ask about it, and they had asked me. And then far as 2 other things I got, we've had a couple comments come in, but no questions. But the 2 other questions I did receive before the live, one was about causes. What are, why younger people what is it different maybe about us than, say, our parents' generation? We're eating healthier. I think that's part of the frustration too. We're eating healthier. We're more aware of what we're eating, exercising more. Not everyone, but we try, just wondering kind of what are some of those main things that you hear about in your work?
Yeah. This is kind of my new obsession. Like, obviously Disparities is always going to be my #1 career interest, but I am kind of becoming obsessed with what is happening that is causing these young cancers, because it's colorectal cancer, but it's also breast and prostate and endometrial. There's about 10 or so cancers that we're seeing in young adults, more so than we saw 10, 20 years ago. And it's probably, the why is probably linked, okay? We don't think it's genetics because the human genome does not change that fast. There is something distinct that happened in people who were born after 1950, 1960, where the risk jumped up. We call that a birth cohort effect. It is most likely environmental. There has been a finger pointed at what we eat and what we nourish ourselves with, particularly the metabolic disarray that those substances can cause, the amount of preservatives. There's a lot of theory even about microplastics and other exposures in the environment. So all of us in the field are convinced that it's something in the environment. We just haven't been able to put our finger on what it is. And I would argue to say at this point that if it was one thing, we would already know. So it's probably a combination of things hitting the people who are unfit or unfortunately predisposed. Because you can take two identical people with the same two exposures over a lifetime, and maybe only one of them will develop cancer. So that person also had a genetic predisposition. So it's kind of like a two-hit phenomena. And we're trying to figure out the two sides of that equation. We are encouraging people to have high fiber diets, low amounts of red meat and processed meat. We want to get rid of tobacco and limit alcohol because we know those are implicated in many cancers. We want to make sure that we have high vitamin C, vitamin D, calcium. These are all things that have shown in studies to be associated with risk of colorectal cancer, meaning more vitamin C better, more vitamin D better, more calcium better, more fiber better, less processed meat, less red meat. So right now we're sticking with what we have, but we know that we haven't really hit the smoking gun. And we're doing a lot of really incredible science right now in environmental epidemiology to try to figure out what those risk factors are. But it's just kind of unfortunate because it's really the millennial age group. It's like the late Gen Zs, the Zennials, as I call us, and the millennials who are going to take the biggest hit from this disease. Anyone who's really born after the 1960s, but even more so 1980s and beyond.
It's incredibly helpful and incredibly interesting to hear your perspective on this because so many people are wondering. The more we hear about this, the more headlines we see what's going on, and really greatly appreciate taking the time to share your perspective. I have one last question. Let me just see. Did I have gone? Oh yes, advocacy.
Yeah.
Because you do so much advocacy work. So yes, there is national, and we both Fight CRC is amazing. I will recommend to everybody if you have not had a chance to connect with people at Fight CRC, you absolutely have to. It's a great opportunity. But it's a lot of it, I mean, I know it's state and national, but I was thinking also about just kind of statewide, wherever you are in your community, like what would you recommend if people are looking to get involved? Not necessarily they're not somebody who knows somebody who is currently, in the midst of colorectal cancer treatment. They haven't had it themselves, but they're in the generation, they want to help. What would you advise that they do and get involved in with advocacy?
Yeah. I love this question but I think that people think that there has to be this big grand thing. Like I marched up to the Capitol building with a big sign. No, I mean, I think you can be an advocate in your own community. You can be an advocate in your own family. Why don't you just start by bringing it up at the dinner table with your parents? Like, have you been screened? Like, do we have cancer in our family? Like, I wish people just knew more about their family history, because if you know about your family history, that's going to tell you when to get screened. That can save lives. Just if people are advocates about that. So I tell people, really start small, start in your family, start in your friend group, start in your community. If you have these passions where you want to take it to a state or a national level, that's fine. But we just need people working like in their own friend group, in the group text,
yeah.
And so I really advocate for that. And then if you have bigger aspirations, yes, we're here to help you find the right people. And you can champion any aspect of it. Like I champion the screening and the early symptoms and the young onset, but you can champion the nutrition. Like I would love to have more people, dietitians in this space, like helping that conversation, or environmental epidemiologists in this space. So find the part of it that you maybe know a little bit about or that you're most interested in, and champion and advocate on that.
Oh, great advice. And especially interesting about the nutrition, since that maybe a part of all this. Be great to have some more nutrition perspectives and kind of educate ourselves a little bit more and help with you work
Yeah.
in that area too. Great idea. Well, Dr. May, thank you so
Thank
much for taking the
you.
time out of, you're so welcome, taking the time out of your very busy schedule to spend time with us tonight. And I know still it's almost night, but not quite yet on the West Coast where you are. But here in Atlanta, it's getting there. But you've taught us so much about how to frame our thinking around these rising colorectal cancer case numbers, and in young people about the age-related healthcare disparities we face, and really, very importantly, ways that we have in our power to successfully be our own advocates, our own health advocates in this space. And there's a lot that we can do. As much work as there is to be done advocating, there's a lot of work that we have that we can do now, that we have the tools to do, and you really empower us to do that. So thank you very much.
Thank you so much for doing what you do for everybody, and keep doing the work, because I know that it's going to make a difference. If we reach one person, that's all we need to do. So thank you so much for having me and for having this conversation.
You're so welcome. Thank you so much. That means so much to me and to our entire team. I want to remind everyone of a couple quick things before we go, that the full recording of tonight's Instagram Live will be posted on our YMyHealth IG feed shortly after this. And I want to encourage everyone to go to YMyHealth.com and check out our latest article featuring Dr. May, where we're going to dive into even more about CRC, and one thing in particular, obesity as the cause. And we were starting to talk a little bit about that tonight, but it's in detail, and how in some way it could be, but in lots of other ways it is not. And so it's very, very interesting. So please check that out, because that's something that we see a lot about, and Dr. May does a wonderful job of explaining all of that to us. And also, you're so welcome. And just want to remind everyone also, if you are not following us here on Instagram yet, please do at YMyHealth, and on TikTok as well. And for more millennial health and wellness content, check out the homepage and subscribe to the newsletter. But thank you everyone for joining, and thank you so much, Dr. May. And this concludes our live.
Thanks, everyone.
Thank you so much.